Good evening, everyone. I want to thank in particular the Institute of Medicine for your work and for your leadership on these issues that really link together in a meaningful way the provision of high quality healthcare and public health. And I'm also really happy to be here as well with the Department of Public Health from Chicago, who just has such a terrific reputation and does such outstanding work. Let's see. So currently, I've worked as a government official for about 30 years. I was the City of Boston's health commissioner, the Massachusetts health commissioner, as you heard, and I had the opportunity to work at the Centers for Disease Control. And now I work on federal policy issues in Washington, working closely with both the administration and with Congress around considering the policies that really make sense in terms of promoting health. And so what you'll hear is some of the thinking that we're engaged in Washington as we are working with both policymakers in the legislative and executive branches. Now, when we work on those issues in Washington at a very high level, it's really easy to get very abstract and forget about the core of why we're working on these health issues. And so in my presentation tonight, I really want to ground it in the reality of a real person, someone who is facing these issues, and talk about how policies relate to that particular person as a way of illustrating why we need to focus in a particular way. So let me introduce you to Ms. Fran Edwards, and I suspect that a number of you have in your practice patients who have some of the same characteristics of Ms. Edwards. She's one of the people who benefited from the Affordable Care Act. She was previously uninsured, and then she received health insurance, as hundreds of thousands of people did in Illinois with the passage of the ACA. And so she is now, after years of not getting regular care, getting good, high-quality care from an excellent physician, an excellent, enlightened and committed physician. And that person, that doctor, is treating her for a number of the health concerns that she has, and she's pregnant, but she also has some health risks associated with the fact that she smokes. She has prediabetes, she has asthma, but she's getting good care for that, and she's really being followed. She's taking her medication, and she is striving for optimal health for herself and for her baby. And so if we were having this discussion maybe a decade ago, we might say, have we done all we need to do for Miss Edwards? We've gotten for her excellent health care, and now she's on the track for having a healthy pregnancy outcome. And I think now increasingly we understand the answer to that is clearly no. Receiving high quality health care is a necessary but insufficient part of optimizing health. And why is that? Again, to take the example of Miss Edwards specifically, well, she is a low income. And so she lives with her in-laws, a little bit crowded in the apartment that she's in. She wants to eat healthy food, but in her neighborhood there are no stores that are selling fresh fruits and vegetables. There are convenience stores. And even if there were, she would be worried about how much it might cost her to buy those items because she's on such a tight budget. She wants to do the right thing, but she's got these impediments in the way. In addition to that, as I mentioned before, she has asthma and she's taking her asthma medication. That helps. But she's actually living in an apartment where there's mold and mildew. And so that's triggering her asthma, even though she's getting good health care. So it's important to think about, as part of optimizing health, not just the clinical care, but these other factors in her life, which are significant in terms of whether or not she was going to be in the ideal health that she should be in. Now, again, I said her doctor's great, and so her doctor actually recognizes that these are important to address, and her doctor decides that the first thing that she's going to work on with Miss Edwards is the housing issue. She's living in overcrowded housing, and she's got mold and mildew, so she wants to get her into housing. And her doctor knows, this is what I'm going to do to help. I'm going to get her, I'm going to connect her to the place where she can get an application for affordable housing so that she'll be able to have that as an opportunity. But what she finds is she refers Miss Edwards there, and Miss Edwards is getting on a waiting list that's probably 5 years long. She's pretty much told, we've got your application, that's great, but there are other people that are higher priority, been on longer than you, so maybe 5 years it'll take. So clearly that's almost like there wasn't a point. Because what she needs is that she needs it now. And her situation isn't unusual. I mean, what we found as we look state by state, city by city, is this is what we find. When we look at these factors that I'll refer to as the social determinants of health that are related to housing, that are related to income, safety in neighborhoods, the social determinants that affect health, there are these major barriers that are keeping people on waiting lists for years, or doctors identifying the need, and then there's nowhere to actually link the patient to get the services that they need. This is just the data from Illinois itself as compared to the United States. In the United States, HUD has estimated, this is the federal government, that there may be more than 7 million units of housing that are affordable housing that we don't have to meet the needs. So we're about 7 million at a national level. And studies in the state of Illinois have estimated that it may be hundreds of thousands of affordable units that aren't available. Now, that's just looking at the housing. We could look at these other aspects in terms of her income, in terms of her availability to healthy food. But those are major obstacles. They're major obstacles to her achieving the health that she wants. So we in Washington have really struggled about this. How do we make the point that we need to ensure that people have high quality health care that's affordable and available to them, but we need to marry that with addressing the social determinants of health and making sure that we're not just identifying the need, but we're making sure we can meet that need. A concept that people have found useful in thinking about that is to essentially think about this as a stream, upstream and downstream. And the notion of downstream is, in this analogy, is, people are in the river, they're drowning, and you're pulling them out. And some of you may feel that way for patients, that they've got really difficult conditions in their lives, and you're sort of trying at a moment of when they're seriously ill or they're in crisis to help them out. That's kind of working at the downstream level. It's critically important. And much of our healthcare system is designed to address the people's needs at the downstream point, when they're really sick, when they're really desperate. That's what insurance will pay for that. But what this suggests is that there really are 3 places in the stream you can work. The middle point of the stream involves a patient like Miss Edwards, where she's being screened for her needs, and they're being identified. Okay, there's some issues in terms of her affording food. Maybe we can get her onto to the SNAP program or onto food stamps. That's a way of sort of addressing an immediate need. Maybe we can get her to fill out the application. That's working on a patient-by-patient basis. Once that patient's needs have been identified, linking them to a particular service. And increasingly, healthcare systems like the ones in Illinois are doing a really good job of identifying those needs and trying very hard, sometimes with social workers, sometimes with nurses, sometimes with community health workers or the health leads folks, to make those connections. That's what we would call midstream. But if we were thinking upstream, it's really thinking about not just the patient at the point that the patient has an immediate need, but are there policies that can be put in place? Are there laws that can be passed that would change the overall conditions so that there would be fewer people, in the analogy, fewer people falling into the stream? Maybe you build a bridge or you build a fence to keep that from happening. In the case of Miss Edwards, it would be about thinking, is there a way to increase the affordable housing in the city and the state writ large, not just having someone be on the waiting list, but making sure that the supply of housing is available in this one particular example. What we would say from a policy perspective in my organization and with a number of the organizations that we work with is that if we're going to address these social determinants, we need to think about working collectively across sectors, and we need to think about them as if they're on a spectrum. The healthcare providers, those of you who are here, play a critical role in terms of screening patients on a routine basis to identify, are there issues in their lives that are going to be impediments to your advice to them, the clinical advice about eating well or exercising, for example. Identifying those needs is key. And then that's the first column, if you will, on the left. A second column that also is very much in the arena of healthcare providers is referring people to the services that exist in the community when you identify the need exists. And increasingly, I think that's a burden. It's a new role for clinicians to really become that familiar with every single agency that might be useful in terms of referring the patient. But knowing that is, I think, increasingly part of the practice of medicine. So that's the second part. That's making sure that you've identified the need through screening. Second part is making those referrals. And again, there's some good models with such things as health leads nationally. The middle one also just identifies that many of our health systems and our hospitals also are key anchor institutions, if you will, within their communities. And they make a big difference in terms of doing everything from where they invest their community benefits, where they invest their endowment in terms, do they put it into housing? Do they put it into community development? Do they hire people from the community? Do they have career ladders for people from the community? So that's an important role as well. And then those two columns on the right are really more of what we look to the public health department to do, but also what we look to other sectors to do and elected officials to do. And that is making sure that if you're building that bridge from the clinical practice into the community service, there's something on the other side of the bridge. And that involves both on the fourth pillar, it involves supporting the budgets of those community agencies to which you're referring people to make sure they've got the resources. The fifth column involves actually changing laws. Just an example of that, when I was the Boston Health Commissioner, is the mayor put in place a policy that said that for every 100 units of housing, 20 units of housing needed to be affordable. And that the builders could either design that into their facilities, or they could pay for a certain amount of money into a pool that then the mayor could use to support affordable housing. That's just one example, but it's an example of how you would think on a policy level, how do we build that, make sure that there's more affordable housing? So it's not up to an individual doctor to worry about Miss Edwards. It's really that there's a background of creating solutions so that the problems are not as significant in the doctor's office. Now, there's no sector that can work on all of these five. You've got to get around a table, and everybody has a role. The health systems, the insurers have a role, the health providers have a role, the public health department has a role, the housing department has a role, the city planners. You really need to be sitting at a table together looking at this and saying, what's the need? Let's identify the need by gathering the information from all the clinical practices and public health department. And then how are we going to systematically go about addressing these needs where everybody assumes the role that's natural for them, but in a coordinated way? Now, we think that that should happen at the federal level as well as at the city and the local level. And as you might guess, it's easier to say than to do. You might have heard that there are some challenges working in Washington now. But the interesting thing is that even with these challenges, there are efforts to try to address this at the national level. So an example of that is just about a month ago, the director of CMS, Seema Verma, put out a memo saying that for Medicare recipients, there was going to be allowance for paying for certain aspects of the services associated with social determinants, such things as food or transportation to things other than medical appointments. So in CMS, there's some more openness to this. In CMS, they're also doing the model program that you may have heard about of accountable health communities that is paying for that screening. So at the national level, at CMS, there's a good deal of discussion about this, and we talk to the commercial payers as well. A lot of creative thinking about this now. States are taking the initiative, requesting waivers. The state of North Carolina has requested and received a Medicaid waiver that is, I think, going to be groundbreaking in some ways because it's going to allow for using those Medicaid dollars to pay for some of the services that are linked to housing and linked to food. Now, Medicaid and insurance is never going to pay for all aspects of that. That's got to really, it may help a little bit in terms of the need identification and linking to services and helping some high-risk folks. But the fact that there's a willingness to stretch the historical parameters to include more in insurance is encouraging. We at the national level are working now to propose to Congress and the administration with some good discussions that that the Centers for Disease Control should be funded to fund states like Illinois and cities like Chicago with money to set up a unit that would officially be to address the social determinants of health. Now, I suspect Chicago's already addressing that. I know you're doing terrific work on housing here, but you're probably doing it with limited dollars and certainly with no federal money. So what we'd like to do is, and we're working to do this, is to give grants to the city and the state that would allow them to work on, when I was talking about getting people from these different sectors around a table, public health has a natural role in terms of doing that. And then there are also just national coalitions. The National Coalition for the Impact on Social Determinants of Health I participate in was created by the former governor of Utah, the former Health and Human Services Secretary under George W. Bush. That's an organization now his organization is now working around addressing social determinants of health. So we're hearing these discussions on both sides of the aisle, on the Democratic and the Republican side, with the administration as well as with Congress. There's an openness to dealing with some of these issues in new and creative ways. Sometimes what happens in terms of these discussions is there is a comfort level about what needs to be done in a doctor's office with a patient in front of you, but it gets a little bit foggy about what can you do at a policy level, at the state level or the city level, that you know will work, that you know if you put a policy in place, the conditions will change, people will actually get healthier. To assist in terms of having that kind of information, work's been done at the Centers for Disease Control, as well as with foundations, as well as with the organization that I oversee, the Trust for America's Health. This is an example of what we've recently released about 6 months ago, that is evidence-based policies that states can pass, that if they pass those laws, for the most part, within a relatively short amount of time, people will get healthier. And they'll get healthier with a disproportionate impact on those populations who are at elevated risk. So if you wanted to gather that information, please just Google this document, and it would give you 13 evidence-based policies that, some of which are already in place in Illinois, but if all 13 were put in place in the state or in the city, people would be healthier, and that would help in terms of Miss Edwards, for example, getting the services that she needs. In addition, there's a city-specific approach that's called City Health, that has been created by a foundation called the de Beaumont Foundation, which works specifically with cities on policies that are known to make a difference. If you pass these policies, the population will get healthier. And Chicago has been evaluated in terms of those policies and has been at the top in terms of passing policies that we know to make a difference in terms of people's health. So Chicago's to be applauded in terms of that. But that's an indication of, again, look to those policies that are at the larger level as well as what takes place in the doctor's office. Now, one way to think about how do you support this continuum of care from the doctor's office to the community agency to creating the conditions with laws and with regulations. And one way that has been used across the country to support those kind of coordinated full spectrum approaches has been through creating wellness or prevention trusts. These are funds that are come from a variety of different sources that are specifically intended to pay for the kind of activities that I've been talking about. And I'm delighted to hear that in Chicago you are looking at this and that the Institute of Medicine in Chicago is playing a leadership role in terms of having those discussions and thinking about how you move this idea ahead. I had an opportunity to work on a wellness trust when I was the Commissioner of Public Health in Massachusetts. In 2012, we passed, the legislature that is, passed a law that created a $60 million wellness trust. It was intended to last for 4 years, so we more or less thought $15 million a year. And it was created with an interesting and innovative approach to how to generate the funding, which was the legislature passed a law saying it was going to assess the largest health systems and insurers a certain amount based upon their market share in order to create the $60 million amount, $15 million a year. You might guess that the health systems and the insurers were not wild about this proposal, but the interesting thing was there wasn't a major fight about it from the payers or from the health systems, because I think they realized that there was truth to what I'm discussing, that their ability to control cost, their ability to optimize health, keep people out of the hospital, keep people out of the emergency room, was going to improve if, in fact, the wellness fund made the conditions in people's lives better. So the fund existed for 4 years. It was intended to have a sunset at the end of 4 years, and the Department of Public Health oversaw the administration and distribution of the funds, and they went to a number of good causes. Some discussions, I think in hindsight, people in Massachusetts might say maybe we should have worked on that more on the right side of that spectrum. We worked a little bit too much on the left side of the spectrum with regard to screening and referral. Maybe we should have been thinking more about how to create additional services through laws and through direct funding of other sectors. But in general, I think the sense was this was a good experiment in Massachusetts, and it really demonstrated that you can make a difference in terms of promoting health was an innovative idea. And there are also other examples that I won't go into. At the national level, though, there is a public health and prevention fund that was created by the Affordable Care Act that also distributes money around the country, including to Illinois, to help in terms of public health. So let me just close and then I'll open things up a bit for questions by saying, ultimately, these kind of major policy decisions have to be evaluated in terms of their impact on real people. And so it's important to begin by looking at what those needs are from the patients you're seeing in your practice, from the information that's being gathered citywide by the health department. Think about what those needs are, think about how best to address those needs, and then measure very carefully whether or not the Miss Edwards of the community are getting the services they need, and most importantly, their health is improving. So thank you.
Question is, I had heard that the legislature was considering reappropriating money for the Wellbeing Trust. Does that happen? And what are the prospects if it hasn't?
As I said, the original trust was had a sunset clause at the end of 4 years. And so now there is a proposal that's before the legislature that tinkers a little bit with the idea of the fund, and I think that's under consideration, but it hasn't been passed yet. But I do think it's still in discussion within the Massachusetts legislature.
Thank you for your comments. I think one of the questions that comes up when people are considering these things is the difference between clinical care and then kind of fixing all of the social ills.
That's right.
At the other end of the spectrum. Yes. Can you talk a little bit about the sweet pragmatic spot in between? And when you go back to that PHA CCS, it seemed as though many of them were focused on public health interventions that improve health as opposed to fixing, if you will, all the social determinants.
I think we're actually in a period of transition with regard to health insurance, because as we're moving away from a fee-for-service to value-based contracting, there's greater flexibility in terms of the use of insurance dollars. And we're seeing around the country that that what's being paid for with healthcare dollars is actually changing. There's a greater sensitivity to both screening patients for social determinants of health and then considering how do we push the envelope with what insurance will pay for that may be beyond the traditional. And that includes some things such as the diabetes prevention program, where there's now payment in Medicare for a community-based provision of care. Actually, under Dr. Bauer's leadership, this was developed. The first time ever that there was a multi-session community intervention in YMCAs and other locations with a non-clinician. Now, that really pushes the envelope. The Medicare will now pay for that. It'll pay for home-based community health workers for families that are that have a child with moderate to severe asthma as well. So there is this creative approach to saying, let's change health insurance and push it out so it'll pay for some of these things. So I would say those are the first two columns. Let's not just do the traditional. Let's really do our best to change what insurance will pay for, what takes place within healthcare systems. But what we know is there's only so much you can expect the healthcare system to do on its own or insurers to pay. We've got to have a robust public health department, and we've got to have sufficient funding in housing and transportation. And so what we've really tried to figure out is how do we make sure we're not simply addressing one of these columns and then not addressing the others. We're really trying in Washington and around the country to say we need to fight, if you will, on multiple fronts, making sure that we're paying for each one of these items. I would say in most of the discussions I've gone to in Washington in the last few years, the attention has been on the first column, screening, or the first and second, screening and referral. But there hasn't been the attention to who's going to be paying for those services at the other end. And so the case we're making now is you've got to do that. You got to do that simultaneously, or else you'll just incredibly frustrate clinicians who identify the need and then feel like they can't help their patients once they've identified it. I hope that addresses your question. Yes.
I want to ask about the tension between kind of the top-down and the bottom-up selection of initiatives on this. So the experts can say, gee, we're going to work on diabetes and the problem of a food desert here in the community. But the community may say, we want to work on getting rid of rats and on youth activities. Right. So can you expound on how to solve that tension?
Deal with that. But, you know, when I was a city health commissioner, I would do hearings and community meetings. I would do community meeting after community meeting, and I'd say, well, here's the data. Here are all my data, and it would show you which health issues to work on. Tell me what health issues we should prioritize. And often people would get up in the microphone and they'd say housing. And the first time I heard that, I'd say, oh, no, you misunderstood the question. I was talking about what health, and so health, tell me what the health issues were. The next person got up to the microphone and said, no, you don't understand. Housing is directly related to our health. So I guess I would say, I think it's both a top-down and a bottom-up, because I think the public health department and the healthcare clinicians are going to know the data, and the data really are important. You know, it's important. We were talking earlier about these, the differences in communities by these different causes. That's critically important. People need to know that in the community, and so you want to share that information, and that's gathered by officials. You also want to share what we know that works, because we don't want people to be addressing an issue with something that's been proven not to be effective. But then, when you decide, well, what do you prioritize? Where do you begin? It's got to begin at the grassroots level, and it's got to be that the people in the communities that are the focus of attention have to be at the table, identifying those priorities, not just once, but throughout the whole process, helping to shape the decisions, help implement the processes, evaluating their effectiveness. So I think it's a partnership. I think it's a partnership, and too often I think we haven't involved the community voices enough. So I appreciate your asking that. I think we really need to think, how do we do that in an authentic way that's not just we did a hearing, that's all we need to do, but in a meaningful way. Thanks.
when you think about some of these challenges, housing, employability, government comes to mind as the place where the heavy lifting
Yes.
is done.
Yes.
With that mindset, are there countries that come to mind that have best practices in that arena that have accomplished things that we have not here in the States? And then also, how do you advocate a role for an organization such as ours, building a trust to work with government? Is it about advocacy, or is it about establishing practice models that can become best practices for, you know what I mean?
Sure. Well, with regard to your first question, I think we have seen when we compare ourselves to other countries, and particularly other countries that have the European countries, other countries where the economies are strong and the healthcare systems are in some ways comparable to the U.S. They've really approached thinking about health differently than we have. On average, if we look in other countries and we look at the amount of funding that's spent on social services, for example, relative to the amount of money that's spent on health services, for more or less for the countries I was referring to, for every dollar of healthcare, they may be spending $2 on social services, and including such things as affordable housing. When we look at the United States, for every dollar we spend on healthcare, we spend about 50 cents on those. So we clearly have different priorities. We put our money into high-tech medicine. We haven't put our money into creating healthy conditions for people. So I think that's part of why we're seeing in many of these other countries that their health outcomes are better than ours. Their people are living longer. They're living healthier lives. They have less of the chronic diseases and infant mortality than we have in the U.S. So I think we can learn about that balance in terms of where you put your investment. In terms of the Institute of Medicine, I would say I'm not the best person for that. I think you need to figure out the Chicago best approach. And my own sense is the best decisions are made when you get everyone around a table and people are collaborating and jointly identifying the problem and figuring out the division of labor. And if you use this kind of approach as a model, saying, okay, well, we've got people working in 3 of the columns. How are we going to fill that other column? Because then you might shift a little bit. Different organizations might say, okay, we didn't plan on emphasizing that, but we're going to put our resources into that one because nobody else seems to, and we need to make sure we're working on all fronts. So I think it really would depend on you all deciding what makes sense given the conditions here.
Thank you.
Thank you. Thanks.